When dealing with a diabetic foot ulcer that has reached the hallux sesamoid complex, the clinical stakes are high. These tiny bones, embedded within the tendons under the first metatarsal head, often act as a nest for deep-seated infection. But here's the good news. Because the sesamoids are small, discrete anatomical units, surgically excising them, a sesamoidectomy, can radically shorten your patient's path to recovery. The question I get most often is, if I take the sesamoids out, do I still need weeks of antibiotics? According to the latest 2023 IWGDF and IDSA guidelines, the answer is usually not. If you have successfully excised the entire infected sesamoid and there is no residual soft tissue infection, the recommended antibiotic course is just 2 to 5 days. Think about that. We are moving from the old school 6-week standard to less than a week of therapy, simply because the surgical resection was anatomically complete. However, sesamoid surgery requires precision in the OR to guide your postoperative plan. You should follow this tiered framework. First, if the sesamoids are out and the site is clean, stop at 5 days. Second, if the bone is gone but you're still fighting a surrounding soft tissue infection, extend to 1 to 2 weeks. Third, if you send your bone margins to the lab and they come back positive, meaning the infection may have tracked into the metatarsal head, you need to push that course to 3 weeks. Finally, if you only debrided the area but left dead or infected bone behind, you must fall back to the full 6-week course. The pro tip here is all in the pathology. Don't just discard those sesamoids. Send the resected bone and the margins for both culture and histopathology. That lab report is your legal and clinical justification for stopping antibiotics early. Once the patient is stable, you can often switch from IV to oral antibiotics with high bioavailability, like clindamycin or fluoroquinolones, to finish the course. In sesamoid osteomyelitis, surgery isn't just an intervention, it's an antibiotic-sparing strategy. By removing the anatomical source, we can save the patient weeks of unnecessary medication, but only if we are meticulous about confirming our margins.